This is in week 3, February 4th, lecture on muscle tissue. Get rid of that. Okay, finally we get out of that cellular stuff. We started off with bones and ossification, and that was fine. Then we slipped out of that for a bit. Now we're going to be in true anatomy for the rest of the semester. This says 9.3. That's incorrect. I guess I didn't change that. Sorry. It is 2.4. Functions of the muscle are listed here. Nothing that you wouldn't think of yourself given enough time. Motion, of course. Locomotion. What's the difference? Motion could be, for instance, clenching my fist. Locomotion, though, is movement. So I might be walking, for instance. Maintenance of posture, just holding your head upright, okay? Takes muscles on both sides of the head to be active. Production of heat. Well, sometimes you may shiver. Most people haven't shivered in a long time. Okay? But if you were to, that would be a source of heat production, and it's by the muscles. And then the circulation of blood itself is really helped out by muscle tissue. Obviously, the heart, being a muscle, is going to be involved in circulation, but the vessels themselves constrict and push the blood along. We have 3 types of muscle: skeletal, cardiac, and smooth muscle. Now, smooth muscle is also known as visceral muscle, visceral meaning of the body. And these terms get used interchangeably, so be ready to interchange them. Skeletal muscle, we look at it and we say, is it voluntary? In other words, could you have control over its motion? And is it striated? Does it have streaks running through it to help identify it? What would you say to skeletal muscle being voluntary? You do know the answer.
It's not voluntary.
Anybody else? Actually, the answer is right in front of you here. Yes, it is voluntary. Skeletal muscle is considered to be voluntary muscle. Okay. So skeletal muscle in the forearm, for instance, might move the wrist. Skeletal muscle in the upper arm might move the lower arm. Okay. So we say it's voluntary. There are times when skeletal muscle is actually not voluntary. For instance, when you shiver, okay, skeletal muscle can move. Have you ever had your eye uh, blink or I don't know the words here, blink sort of uncontrollably, or you got a spot on your face or even on your arm that pulsates and you're not doing it? Okay, well, that would certainly be involuntary, but it's rare. Skeletal muscle party line is that it is voluntary, please. Is it striated? Yes, and we'll see a picture of it in just a second. Cardiac muscle, muscle of the heart, is it voluntary? Well, I've highlighted the answer for you. It's not considered to be voluntary. I disagree a little bit with that because can't you slow your heart down? Can't you speed your heart up? Take a run around the block and you speed your heart up, cardio, okay? And you can slow your heart down as well. But the party line and the answer on any test that we have is that cardiac muscle is no, not voluntary. Smooth muscle or visceral muscle. This would be like, for instance, muscle of the stomach, muscle of the small intestine, muscle of the internal organs. Is it voluntary? No, it's not voluntary. Okay. The movement of material through the small and large intestines is not voluntary on your part. And is it striated? No, this muscle is the one of the three that is not striated. And I'll show you that in the picture coming right up. This is skeletal muscle. The skeletal muscle shows obvious bands and striations going across them. This is just under the light microscope. It has nuclei that are peripheral. So if you look at each band not as a flat tapeworm, but instead as a cylinder, okay, circular cross section, these are on the periphery. When you find a nucleus that looks to be in the middle, it's not. It's on the other side, showing through. Same thing here and here and here. Skeletal muscle does not branch. So you get these bands that are continuous. That's all repeated here. This is cardiac muscle. Cardiac muscle has more centralized nuclei. Cardiac muscle does branch. Here it's branching. Here it's branching. Branching. Looks more like a freeway. Here's a branch. Okay. They also, cardiac muscle has what we call intercalated discs. That's these structures here. It is striated, but the striations are lighter, and they're here. But the intercalated disc is thicker and shows up here. Depending upon whose microscopic preparation you're looking at, sometimes this is very clear, as you see here, and occasionally it's not clear at all. I will only show you specimens that are clear. Okay, but at any time you need to. This is smooth muscle, the one we also call visceral muscle. The nuclei are elongated and dark. There are no striations or streaks going across. To me, how do I remember this one? Once you learn somebody's name and once they have done something good for you or nice to you, you probably never forget them. Well, this one doesn't do anything nice to me at first until I look at it and think, I'm looking in running water like a stream, and there are fish and other animals swimming around inside of it. no striations. Here's a skeletal muscle. We don't need to name it. We can. Uh, now, this could be the soleus muscle, but you're not there yet. We're not. So let's just look at this muscle. The function of the muscle, there's only one real function. We listed functions, five of them, at the very start of this, at the top of the page. But there's really only one thing a muscle can do, and that is contract, get shorter. Okay. How does it get longer again? How does it get back? Gravity will pull it back once you stop contracting, or another set of muscles will pull it the opposite direction, antagonistic muscles. One end of the muscle is the origin. Okay. This is the part that attaches to the stationary end of a muscle. If this is the origin, this end is the insertion. When the muscle contracts, the origin stays relatively stable and still, and the insertion pulls up towards the origin. Can't pull up forever, it can't contract forever, but it contracts enough. Now, the word tendon here is like when we looked at the knee the other day. A tendon attaches a muscle to a bone. The bone is not being shown here. Okay? The origin and the insertion through tendons both will connect to bones. The middle has the very anatomical name, belly. This is the belly of the muscle. I've put it into words for you. The origin is the end of the muscle that is relatively stationary during contraction. The insertion is the end of the muscle that moves towards the origin during contraction. A sort of disclaimer here, rarely a muscle can act as the insertion and vice versa, it can act as the origin. This is rare, but for instance, if you feel your or know where your rectus abdominis muscle is, your six pack muscles, okay, they come and start at the xiphoid process and they terminate at the pubic uh, symphysis. If you were lying on your back and you pull your legs up, you flex your thighs, pull your pelvic region up towards your chest, then the origin is at the xiphoid process and the insertion is at the pubic symphysis. On the other hand, same muscle, we're going to be working here, the rectus abdominis, six pack muscle. You're flat on the ground, okay, and now you're going to do a sit up. Try to keep your legs on the floor and you're going to try to raise your body. The part that's moving is the xiphoid process, so it becomes the insertion. And the part that stays stationary in this case is the portion near the pubic symphysis, so it becomes the origin. It's only occasionally in the body that we have a muscle that can work both ways. It depends on how we intend to use it. Okay. Some common actions. Flexion. Flexion is the action of a muscle when the angle at the joint decreases. Hold your arm either imaginarily or for real. Hold your arm straight out and now fold your forearm over your upper arm. Okay. Bring it up and you have flexed. You have flexed the forearm. Flexion means to decrease the angle. The angle started off at 180 degrees. You went past 90. You probably went quite a distance past it. That's flexion. Extension is just the opposite. So if you got your arm in that same flexed position, now we'll extend it. But the um, muscle that flexed the forearm is primarily the biceps, and it can't help you now. The extension of the forearm is done by the triceps on the underside of the upper arm. So that contracts and the action is extension. Abduction is when you move a part of the body away from the center line. So if you had your hands straight down at your side, okay, and you then like you flare them out, you spread them outward or try to raise them. You're moving them away from the body. That's abduction, like to abduct. And adduction is to let them fall towards the body. Now, you can put your arms at your side, and you may say they're abducted, but to really ADD, adduct, you need to put pressure inward towards the middle line. Pronation is to turn your palms down. Okay. This is from the anatomical position where their palms are facing forward. To turn your palms downward, in other words, the anterior now is the back of your hand. That's pronation. And then supination is to turn the palms back upwards again. This is bone, this is the tendon, and this is muscle. Okay. We don't say or know, looking at this picture, whether this is the origin or the insertion, the part that will move or the part that stays stationary. That doesn't show in this particular picture. This is the sort of way a muscle would look like if it were cut across. And if it were possible to draw like a telescope parts of it out, parts of it out. Okay. Well, it's not possible to do that, but for illustration, it really helps. The muscle itself is surrounded by connective tissue. It's a shiny connective tissue. It's shown here where I have the epimysium. This is epimysium here. This is epimysium as well. Epimysium is the outer layer of a muscle. If we were in lab and you had muscle tissue in front of you, you would peel this stuff away so that you could see the muscle even better. But we don't have to peel it away here. Inside of the muscle are a number of rod-like structures. These are called the fasciculi. Okay, here's a fascicle, and here's one fascicle pulled out. How many more are left? Well, at least one, two, three, four, five, six. I don't know if there's a seventh one behind there or not. This is a fascicle. This is a fascicle. This is a fascicle. And every fascicle has a membrane around it. I'm going around the membrane. Here's its name, the paramecium. Paramecium. So first we have the epimecium on the outside, and then inside of our packet we have the paramecium. Each one of these small inclusions in the fascicle that I'm touching right now is equivalent of this piece that is being drawn out. This is a muscle fiber. A muscle fiber is the same thing exactly as a muscle cell. Those terms that get used interchangeably and you can't be confused by those. Here's the muscle cell. Around every muscle cell, there's another membrane, shown lighter. And that is the endomysium. The endomysium is between muscle fibers and upon them as well. So we have three layers. We have the epimysium out here, the paramecium around the fascicle, and the endomysium around and between the muscle fibers or muscle cells. If you look around in other books or on Google, you'll appreciate how nice this drawing is. This is a similar drawing. Here's the belly of the muscle, the tendons back here. The epimysium is on the surface. Here's the name. Now they're calling it deep fascia. I won't call it that. Okay, I'll call it epimysium. Here's a fasciculus drawn out, and the fasciculus has paramecium around it. And then I'm going to pull out another portion. This is unlabeled. It's almost unforgivable that it's unlabeled because it's in a fascicle. That's the fascicle here. And you're pulling out the next part, which is the muscle cell. This is the muscle cell or muscle fiber. And it's surrounded by the endomysium. That's labeled right here. So the part on this diagram that's similar to the one we just looked up above is the muscle belly here, the epimysium, the fascicles, and from that we can pull out a fascicle, and the surrounding the fascicle is the paramecium, and then pulling out a little farther, we pull out a muscle cell or muscle fiber. It was surrounded by the endomysium. The drawing is not similar past this point. At this point right here, the drawing ends its similarity to the one we just saw. The sarcolemma, sarcoplasm, myofibril, we will be going into when we come back from the, was it President's Day holiday? I'm tired of the presidents. Okay, that's it. There we go. Okay, hang in there for just a second. I'm going to get some bones that are right behind me. Okay, I'm back. I've got the bones, but they don't show on the screen. So let me see if I can raise this chair. No, no. No. Oh, damn. That was stupid of me to wear some confusing shirt. But I think this will work. Okay. You're able to see the pelvic bone?
Yes.
Yes.
Okay. If you recall, when we ended on Tuesday, we had gone over the drawings, but I hadn't gone over the real bones. So I'm going to do that. I'll do it fairly fast, slowing down for the harder portions. Okay. I don't know. You tell me if this is true. You actually see the full screen.
Yes.
I see the
Because
full
I'm
screen.
okay. Because all I get to see here is a tiny little bit. Maybe if I go. Okay, now I can see myself. Can you still see the full screen?
Yeah.
Yeah.
Okay,
Yes.
that's great because now I can see what I'm showing you. Okay, this is the pelvic bone. Let's start with something very obvious and easy. Here's the uh, obturator foramen.
Excuse me, Charlie. Do you mind me asking what view is this for us? Are we looking at it posteriorly or anteriorly?
Now I'm showing it to you anatomically. Okay, so in other words, you're seeing it anteriorly. Okay, this is lateral. You can see in here, here's part of the pelvic brim. And I haven't, quite honed my skills because everything I do and look at here is backwards. So I'm going one way and it's going the other. But if I take my time, I'm fine. Okay, so this should help you orient. This is the pubic symphysis. And it comes in like this. Okay, here's the pubic symphysis. Up at the top is the pubic crest. This was the obturator foramen. And then on behind, on the hind side, this is the ischial tuberosity. The obturator foramen right here. Ischial tuberosity behind it. Looking from this side, you're looking from the inside. This is the obturator foramen. This is the pubic crest. And here's the pubic symphysis in the front. You got to try this. This is not easy. Okay. And that's the pubic symphysis. There's the pubic crest. This large notch up here is the sciatic, greater sciatic notch. When we come down from it, greater sciatic notch, we come to this point here. This is the ischial spine. And this below that is the lesser sciatic notch, quite a bit smaller. My hand is holding the anterior. Okay. Back here is the ischial tuberosity again. We should know the obturator foramen. And then the head of the femur fits into here. And this is the acetabulum. This upper portion is the ilium. The three bones, the ilium, the ischium, and the pubis. This is the iliac crest. Now you see this portion here where it's roughened. What's going to go into there or articulate at that point is going to be the pelvic region, the sacrum. I'm sorry, the sacrum's going into there to make the sacroiliac joint. Put my marker on the iliac crest, and I'm going to come forward now. This is going to be coming forward. That's good. This point here is the anterior superior iliac spine, whereas below it is the anterior inferior iliac spine. In the posterior area, which we recognize because of this sacroiliac marking, we come back first to this point, and that's the posterior superior iliac spine. Drop down, and that's the posterior inferior iliac spine. Now, if you can see it, there's an ear-like marking. It's right here. If you don't see it, it's there. You have to take the word for it. There it is. Looks like a check mark. That's the auricular surface, meaning ear-like surface. It's not an ear, obviously, but it has the look of an ear. And it's going to articulate with the auricular surface of the sacrum. Okay. Well, despite some fumbling, I got to all of them, and they're all being recorded. So if you need to look at this and see a real bone, fine, you'll have this. The next bone, this is the femur, the longest, heaviest bone in the body. The head of the femur is over here, and it has an indentation in it. You can see it right here. That indentation is the fovea capitis. Fovea capitis. It allows for extra room for the synovial pouch. This is the head. Drop back to the neck. We often ask the neck, even though it seems like that's too easy. There are two projections, here and here. These are trochanters. A small projection might be a tubercle, as on the rib. A larger one might be a tuberosity, as on the radius. But these are the largest, these are the trochanters. And the upper one is the greater trochanter, and it's lateral, because obviously the head must be medial. And the lateral trochanter, which we don't call it that, is the greater trochanter, and down here is the lesser trochanter. The intertrochanteric crest is the portion here that makes the moon. This is the intertrochanteric crest. I'm going to spin it around. Now you're looking at the anterior side. This is anterior. Here's the greater trochanter. Here's the lesser trochanter. Very, very important attachment points for the muscles of the leg. Okay. Here's the shaft. As I come down to about mid-line where I'm holding it, my thumb is now touching a ridge on the back side. You can barely see the ridge coming in and out here, but it's very noticeable to the touch. There it is. That's the linea aspera. Linea aspera. And the hamstring muscles will attach at that point. We come down to the distal end. We want anterior view, and that's what I'm showing you, because this is nice and smooth here on the anterior side, whereas on the posterior side, you've got a big notch. On the anterior side, this smooth area is the patellar plate. It has other names. Popliteal plate. Patellar surface. That's the one that your book uses. There's the patellar surface, and the patella rubs against that. Now, as far as this structure and this one over here, these are large, these are condyles. These are not epicondyles. They do have a small little point. That's an epicondyle. But when we're talking about the femur, we want to talk about the large structures, the condyles. And you can see the condyles going underneath and over to the other side. Those condyles are called lateral condyle or medial condyle. Well, how do you know? Well, that's very simple, because you'll see the whole bone and you'll go up to the top. Okay, here's the head. It must be medial, follow down, and this must be the medial condyle. The other one has to be the lateral condyle. Turn it around. Okay. Are you seeing the same thing? Okay. I don't know what happened there. Okay. You have the space in between. That's the intercondylar fossa. These two condyles are going to set on two condyles of the same name on the next bone below. That's the tibia. Here's the anatomical view of the tibia. You're looking at it from the front. Some things are symmetrical, so that's nice. At the very top, this saddleback peak, looks like it, two peaks anyway. This is the intercondylar eminence. Intercondylar eminence. On the front upper knee, you have this bulge or bony projection. This is the tibial tuberosity. This is a condyle. This is a condyle. But as to which is lateral and which is medial, we can't tell looking at this until we go down to the distal end. Okay, what we're looking for is this projection. This is on the medial side. This is the medial malleolus we talked about the other day. If this is medial, and I can hold it by that bone piece only, then I go up, and then this must be the medial condyle. This must be the lateral condyle. If you have paper and pencil or something to write with, I'm going to add something. I don't think it, or you could check me out and see if it's on the list. At the very front, where you would call this your shin, there's a ridge on the very front, and that is the anterior border. Would you check, please, and see if it's on your sheet, those who have the sheet, and if it's not, tell me, and I'll have you write it down. Anterior border.
Yeah, on the PowerPoint of the bones and structures lower appendicular, it
Yeah.
does say anterior border.
Okay. And I provided you with that PowerPoint?
Yes.
Okay, then we're fine. The anterior border, when I point out something at the last minute and then the rest of the review that we're going to have today, when I point out something at the last minute, or if I point out something for the first time and it was never done before, you can take my word for it. It will be on the test. And nobody ever misses it then. Okay. But there are some things that are in the test already, and the test is a son of a gun to put together if you to change one question. Okay, so I won't change the question. I would accommodate you by teaching it to you and promising that it'd be on the test. Okay, so here's the anterior border. Come down to the lower portion once again. This is the medial malleolus, and on the other side, right here, that's the fibular notch. The fibula is going to go into that. I just have to move this around so I get the best picture. There it is. The fibula. Okay, barely get it in here. One end is the head, the other end is the lateral malleolus. And in order to determine that is not easy. You rotate one end. Let's see, I'll take, here you go. I rotate this end. I ask myself, does that possibly look like the head of a snake? Or does it look more cubic or cuboid? Now let me try the other side. Does that look more like the head of a snake? Oh, see that indentation? That's the mouth of the snake. Okay. That part looks like a snake to me, but I can't seem to get it in focus. Okay, so this part is going to go down. And this part that I'm holding is going to be the lateral malleolus. Whereas the other part, which is more cube shaped, think you can see that, is going to be the head of the fibula. I tend to, when I make a question though, put this together along with the tibia. If the fibula and the tibia go together, the head is always upright and the lateral malleolus is always down. Okay, so I don't think you'll really have any trouble. It is frustrating the first time you go through this and try to figure out which end is which, especially since you don't have this bone uh, in your room. Okay, so it'll be a fair question. Okay, the head will be upright and the medial malleolus will be down. I'm going to take it off screen for a second. Okay, there's the medial malleolus, and on the other side, the lateral malleolus. Going up to the top, well, these weren't from the same kit, obviously, or they would have come together better. This is the head of the fibula, and it's right underneath the lateral condyle, right underneath the lateral condyle of the tibia. The only other set of bones to do are the foot. Okay. And the foot's not going to be difficult for you at all. Okay, the big toe. The big toe has a distal and a proximal phalanx. That's it. The other 3, 4 digits are listed as digits 2, 3, 4, and 5. When you identify them, you want to identify them by their digit number. So for instance, going back to the big toe, this is the proximal phalanx of digit 1. This is the distal phalanx of digit 1. Take the one in the middle here on the next toe, and you have the middle phalanx of digit 2. Okay. When you have done all 14 of them, you can cross 14 of them off of your list. Above those are 5 metatarsals. Metatarsal 1, 2, 3, 4, 5. The only difficulty with the metatarsals, because they're numbered, is so easy, is when somebody calls them metacarpals instead. So be sure if the question provides both type of answers that you call these metatarsals. Okay? 1, 2, 3, 4, and 5 over here. I'm holding metatarsal 1. It's coming down to a bone here. This is cuneiform 1. Metatarsal 2 articulates with cuneiform 2. And metatarsal 3 works with cuneiform 3. Okay, there they are. 1, 2, 3. Please do yourself a favor, call them cuneiforms. Okay, I wrote this test and I used the term cuneiform. So you're not helping yourself out by learning them as lateral and medial cuneiforms. So cuneiform 1, 2, 3, and the next larger one is the cuboid. And this articulates with metatarsals 4 and 5 above. The cuboid here behind it articulates with the largest bone, the calcaneus, the heel. Sitting upon the calcaneus up here, rounded bone, at least it's rounded in this view. This is the talus. And forward of the talus here's the talus, and forward of it, coming down, we're coming to this bone here. This bone is the navicular. It's above my index finger. That's the navicular bone. Okay. The navicular can also be called the scaphoid. Only 7 tarsals, that's the proper word, tarsal here, and metatarsals, and then we have the phalanges. In the wrist, it's carpals, and above the wrist in the palm of the hand, it's metacarpals. Lots of pictures in the books, lots of pictures in the notes for this guy, and always looks better when they're strung together well. Okay. Okay, it's 19 after. Let's take a break. Come back at 3:30, and I'll start with a review for you. Now, if you don't need review, don't come back. Don't waste your time. I don't know anybody who doesn't need review and couldn't benefit from it. But if you decide to manage your time such that you would rather do it later, it is being recorded and you can watch the recording. Okay, so we'll see you in 10 minutes. Okay, can you hear me?
Yep. I can hear you.
Thank you. It told me I was muted. I don't know how that happened. Doesn't matter. Did you, anybody think of a question?
Yes, I have a question. So in the modules, for like this week, I went under the bones and figures for like the lower appendicular skeleton, and I saw that it brought me to here I'm doing it to the up. It gave me a list of the upper appendicular skeleton, not the lower, like with all the figures and or
Okay.
give you the figures.
When did you look at that?
Just right now.
Right now?
Yeah. I just
Because
didn't know if it was my computer, like something like that, or if it was actually within like the canvas.
okay, well, because I worked on that yesterday. Somebody else mentioned it. Okay, now this first off, uh, can you find all the information, even though it might be in the wrong spot?
Yeah, I can find it in the book. And you
No,
also
no.
have the PowerPoint, which is nice.
Oh, okay. Now, I know you just said it, but I wasn't. I was thinking and not listening. Tell me what's wrong.
So when I click on the bones and figures location with like it gives you the figure number where to find it in the book.
Yes.
I press on it for the lower appendicular skeleton. It brings me to the upper appendicular skeleton and those figure locations.
Okay. I'll fix that. Okay. So it won't be a problem. Probably look at it in just a moment. Okay. Okay. Thank you, Anna.
Thank you. I just didn't know if it was my computer doing that.
No, no, no. I worked on that exact thing yesterday, and I guess I didn't do a good job. So I will fix it so it goes to where it's supposed to go.
Okay. Thank you, Charlie.
Anybody else? Okay. Are you able to see the screen?
No.
Nope. Okay. Okay. Are you able to see the screen where it says week 3?
No.
No. Okay. Hang in there. Now.
No.
No.
Okay. Do you see the three guys?
Yeah.
We can see your screen.
Yes?
Yes.
Okay, so I don't know how it got off track, but we're back on. So I know how to do that. So modules. Okay, what I'm going to do is go through the labs where bones were involved. Okay, and I'm not going to spend a lot of time on things that I think are just too easy, and you would probably agree with me. You can slow me down if you disagree with me and you want to ask a question. Absolutely. However, I'm going to hone in on the ones that I think would give people trouble. Okay, maybe there's several people who have no trouble with this test at all. But if there is going to be trouble, I'm going to point out where that's going to be. Okay, so I'm not going to skip anything. I'm just going to go faster. Okay, the parietal bones. Obviously, you have to know the two parietal bones. You have to know the four sutures of the skull. Those four sutures are the sagittal, lambdoidal, the squamous or squamosal, and the coronal, which doesn't show in this picture, but it will in another one in a moment. Here's the temporal bone right here. Here's the mastoid process. The mastoid process is a part of the temporal bone. It's a part of the petrous portion. Now, I'm going to mention petrous and the squamous portions of the temporal bone more in just a moment, because that is a sticking point for many students. The occipital protuberance at the back, the occipital bone above it. Okay. There's nothing different on here. This is a repeat, actually, with parietal bone, occipital bone, occipital protuberance, boidal suture, can also be called lambdoid suture, and the sagittal suture. Now, you're not going to get asked what a suture is. You will get asked what a suture is on the lecture test that's coming up right after that. Okay, but you'll have a break of a week to begin studying for that. Another view of the skull, hyoid bone. Maybe we didn't spend much time on it because there's nothing really to say, but some people miss the hyoid bone out of no necessity. You should get that hyoid bone, that horseshoe-shaped bone, the only bone that doesn't have an articulation with another bone. The styloid process is right in front of the mastoid process. The styloid process is another part of the petrous portion of the uh, uh, temporal bone. Okay. Here's the external auditory meatus. Do not be confused with the term external acoustic meatus. They are the same thing. Okay. Here's the zygomatic bone up here, and in the maxilla, this below the eye is the infraorbital foramen. Now, if you see one that's going to give you trouble, or you're having trouble memorizing, you can butt in, like I said, and we can talk about it. On the underside of the skull, the easiest thing is the foramen magnum. But at 10 and 2 o'clock, these condyles, which articulate with C1, These are the occipital condyles. The jugular foramen is a large jagged hole, and looked at straight down, you can't see it go through. You have to look from the teeth area back towards it, and you'll see it go through. Okay, be sure that you identify the jugular foramen from both sides. We'll see the other side in a second. This and this are the carotid foramen, and we don't expect to see them go through because they turn sideways immediately and come out near the structures here, which are the foramen lacerum. Here's where the jaw articulates at the mandibular fossa. And this structure here on the side, the only answer that you're going to be acceptable is zygomatic arch. Do not bother learning temporal process and zygomatic process of the zygomatic arch. Just zygomatic arch. Here's one that has the jugular foramen where it comes out inside the cranial cavity. Here's where the external acoustic or auditory meatus comes out. This is the internal acoustic meatus. The external and internal are not continuous. They go through an area where you have the three ossicles. We'll see those in a moment. Okay. This one is a tough one for students. Internal acoustic meatus. See where it is. It's right above on the intercranial surface. It's right above the jugular foramen. On this profile view, here's the coronal suture. And here's the zygomatic arch we talked about. Now, temporal bone, temporal bone. Squamous is the thin, flatter portion. Down here below it, up here, this is all petrous portion. Petrous means rocky. Okay. The ear canal is part of the petrous portion. The canal itself that goes through and where we find the three ossicles is in the petrous portion. Where we find the internal auditory meatus is in the petrous portion. Where we find anything like the styloid process or the mastoid process, it's in the petrous portion. Where we don't find anything, that's the squamous portion. Above the eye, the supraorbital foramen. And then here at the bridge of the nose, the nasal bone. Then there's a gap where we have the maxilla. And then inside, we have the lacrimal bone. This is the zygomatic bone again. It ends from here and goes to here. Okay. There are pictures in here, but some drawings too. Okay, a lot of people don't understand that the sphenoid bone, which is in yellow, tell me if I'm wrong. It looks sort of like a bird or a bat or some sort of flying wombat or something. Okay, it stretches from right to left and appears on the outside of the cranial case. This is sphenoid. All of this is sphenoid. Here's the sphenoid again. There's a flat surface over here, and that flat surface is the one that you just saw on the side of the head. Inside of the sphenoid bone, you have a manta ray looking structure. That's the lesser wing. Lesser does mean smaller. The greater wing is all down here. All of this, and it has most of the structures associated with it. It has the foramen ovale, foramen spinosum. So go spinosum, ovale, and kick the rotundum. Right here. Right here. The optic canals are located here. You can't see them in this picture, but if you take a stick, a little applicator stick, and insert it, they will come out through the eyes. The optic nerve comes in here. The saddle is the sella turcica. The sella turcica houses the pituitary gland. These two portions are the part of the foramen lacerum. The foramen lacerum is misnamed. A foramen is a hole through a single bone. It will always be that, but it will also always be misnamed when we get to foramen lacerum. You can see that this is not a complete hole. It's broken here because it attaches to another bone. It doesn't go through a single bone. Okay. Here's the sphenoid again. Optic canal. Right here. Everything else we just did. Underneath the sphenoid bone, it's as though it can stand. There's an Egyptian piece of pottery that's been remade millions of times. It's called the footed bowl. You have a bowl up here with 2 feet, and those feet are the pterygoid processes. At this angle here, lifted up, we're able to see the superior orbital fissure. But I have a better picture of it in just a moment. This bone is troublesome. This is inside of the frontal bone. So it's a bone within a bone. And this is the ethmoid. The ethmoid, when it sticks up here in the cranial case, the part that sticks up in the center, that's the crista gully. And then flaring away from it on both sides is the cribriform plate. Here's the name here. The cribriform plate is perforated by the cribriform foramina, also known as the olfactory foramina. because they allow scent to come from the nasal cavity to the brain and to the uh, uh, well, to the scent glands. Think of this as four-parted. The part sticking up towards you, Christogali. The part sticking off to your right here is cribriform plate. The part to the left, cribriform plate. There's a part that is going to go downward as well. Okay, and I'll show you the part coming down in a moment. Okay, the optic foramen again is here, sella turcica. These are repeats. You do not have to know groove for the venous sinus. You do not have to know this. The other material, look at this, petrous part of the temporal bone. Okay, this ridge is part of the petrous portion. It has inside of it the ossicles. Here's the squamous portion out here. Okay, here's where we get to look into the eye and see the superior orbital fissure and inferior orbital fissure, which allows muscles to come in. The fourth part of the ethmoid bone, cristogali, the two flared out portions of the cribriform plate, made up three. Here's the fourth part, right here. It comes down into the nasal cavity. It's called the perpendicular plate. It joins with another bone called the vomer. When you see this, if it's on the test, it's likely to be the perpendicular plate's at the top and the vomer is at the bottom. Here you need your pencil. I'm going to add this because I know it's on the test. And I didn't put it in the guide. Look at these structures here. 1, 2, 3, 4. If you were able to fit your finger into the nasal cavity on one side, you'd find these rib-like structures. Okay, these are nasal conchae. I'll spell conchae after you write nasal. Conchae is C-O-N-C-H-A-E. Along with material that does not preserve, they form shells going across, dividing the nasal cavity really into 6 parts so that the air coming in can adjust to body temperature more readily. So the nasal conchae. The alveolar process is common to both the maxilla and to the manubrium. Mandible, I should have said. I'm not getting that to collapse here, but I don't need it. Okay, here's the palate. It consists of two bones. The one at the back of the mouth and the top back of the mouth is the palatine bone. At the front of the mouth is the palatine process of the maxilla. Palatine process is not part of the palatine bone. The palatine process of the maxilla. This little opening here or here are the palatine foramina. There may be only a single pair. Usually there's a double pair. And then the vomer is here, almost like a pedestal. Okay. The vomer runs all the way to the front of the nasal cavity, but only on the lower half. The upper half is the domain of the perpendicular process of the ethmoid. Okay, on the mandible, body, angle, ramus can give some people problems. Ramus means arm, and this is considered an arm here. On the interior side of the ramus is the mandibular foramen, where ganglia congregate. Here's the mandibular condyle. Mandibular condyle fits into the mandibular fossa of the temporal bone. In front of that is the coronoid process. If you haven't figured out a way to remember that or haven't got it memorized yet, the coronoid process, I always just say, they open my mouth, this will drop towards my heart. This is the alveolar process here. And this little guy, this opening in the body is the mental foramen. Here's the ear bones, the malleus, incus, and stapes. You'll memorize them your own way, I'm sure. The malleus is supposed to look like a hammer. Incus is supposed to look like a anvil, which most people have never seen. Looks like a tooth to me. And the stapes does look like stirrups. Okay. These arrows are pointing to the bones that make up the orbit of the eye. Troublesome is the sphenoid out here. And also this is the sphenoid here. Okay. Sphenoid, that large bone. Then the zygomatic here and in here. Here's the maxilla from here into here. This is the lacrimal. This bone is the ethmoid. How did we get the ethmoid again? This is attached on the inner side to the cribriform plate. Comes down though. This is the frontal bone. And I don't know what the little two is for, but I'm going to say it's for this. And this is the optic foramen. Superior orbital fissure and inferior orbital fissure. I'm going to check out for just a second here. Here we go. Are you seeing a thoracic vertebra?
Yeah.
Okay, good. Okay, the thoracic is the most representative of the vertebra, and you got to know all of its parts. So the body, the vertebral foramen, and then we go around it. So we start with the body and then go to the pedicle. And here is the uh, superior articular process, the part that's sticking up. The flat plate that it has is the facet, superior articular facet. They're both labeled over here. After we pass the superior articular facet and process, we have the lamina, we have the spinous process, lamina again, superior facet again. This structure out here is the transverse process. The term transverse costal facet, that's referring to the articulating area on the end of the transverse process. Here's the transverse process labeled over here. It's all of this. And on every transverse process in the thoracic region, we have a notch. We can call it just a notch. Okay. We need it for articulation of ribs. There are a couple of lines in here, and you may have wondered what they're for. I took those out. I took them out the last semester, and you're not responsible for those structures at the end of the line. They're not labeled. I was unable to get the line out, but I got the label out. Here's C1 and C2. C1 is unique in that it has no body. C2 is unique in that it has this projection that sticks up into that vacancy left by C1. These are cervical vertebrae. There are 7 of them, and only cervical vertebrae have transverse foramina. Over here, we have transverse process. Here's transverse process, but it's got a hole in it, and only the cervical vertebrae have transverse foramina. There are blood vessels and nerves that go through there. Know C1 to be the atlas and C2 to be the axis. C1 to allow you to nod and C2 to turn your head. This is a lumbar vertebra, body articular process at the top, inferior articular process at the bottom. Okay, they're always opposite. And then the spinous process, the largest of the vertebrae. The spinal canal. Here's the base end, mid-sacral crest, middle sacral crest, lots of different names. And here's the apex, base, apex. Here's the sacrohiatus. Nerves come in the spinal canal, which is a tunnel here, and come out the sacrohiatus. We're on the posterior side, so these are the posterior sacral foramina. There'll be 4 pairs. On the anterior side, you get anterior sacral foramina, 4 pairs. In both of the drawings, you get a coccygeal vertebra. It's really composed of 4 fused together vertebra, but we call it one anyway. If we take the sacrum and turn it laterally, we see that ear-like structure that we talked about with the ilium, and this is the articular surface. For the ribs, you know that there are 7 pairs of true ribs. That's 14 ribs. And there are 5 pairs of false ribs, of which the last 2 pairs are actually floating ribs because they have no attachment to the sternum at all. Ribs 8, 9, and 10 do get a ride. They hitch a ride on the costal cartilage of rib 7, but they don't have their own cartilage. The sternum has a body and the manubrium at the top. In the sides of the sternum, wherever costal cartilage joins it, there's an indentation. It's almost like when you pull a tooth, you leave a cavity, you leave a hole. Okay, and those are called costal notches. They don't show here. I'm not going to put anything on the test for you to wonder, should I have seen that? Yes, you should have seen it. And if I didn't show it to you, it's not going to be on the test. Okay. So I wouldn't worry about costal cartilage, costal notch. I would worry about on the rib, head, neck, and then don't forget that this is tubercle. In the radius, it's tuberosity. And in the femur, it's trochanter. Each rib has a groove on its underside, and the rest of it is the body or shaft. The manubrium is the upper part of the sternum. It has a notch at the top, which is the jugular notch, and then 2 on either side of it, the clavicular notches, which should be self-explanatory. You do not need to know the sternal angle. Here's the body, the xiphoid process. On the upper appendicular skeleton, let's see what's troublesome here. The only thing that would give you trouble here is not taking the time to realize that this is anatomical view here. This is the front. So that's the subscapular fossa. Coracoid process, once you have it down, you'll never forget it. The problem with this particular lab, it had a lot of words that started with the letter C, you know. So here's the anterior view. Here's the posterior view. This area up in here, the supraspinous fossa and the infraspinous fossa down below. And looking at these pictures, if you are this weekend, notice the acromion over here on the left and the acromion here, okay, and how it flares up. Okay. This is unlabeled, yet no, it's labeled. The scapular spine here. The glenoid cavity can also be called the glenoid fossa. You'd think in anatomy, which should be a precise science, they wouldn't have two names for everything, but they do. On the clavicle, okay, this one happens to be a right clavicle. One end is bigger, and that's going to be the acromial end, the end that touches the acromion, which is also big. The other end is going to be rounder, okay, and that's the sternal end. It fits into the clavicular notch, the sternal end does. Okay. Go back out to the acromial end, and come back about an inch, and there's a bump. That's the conoid tubercle here on this side. You'll wonder what the hell the conoid tubercle does, but when you see it in an articulated skeleton, you can see that what it does, it makes a cushion uh, between bones. It helps the uh, clavicle rest upon C1 without harming it. I'm not going to ask you right or left here. I am going to ask you right or left on a few of the straightforward bones. For instance, we looked at the femur today. Okay, I would feel as long as you had a good look at it and some time that you ought to be able to tell me if it's right or left. Okay, for instance, humerus here. Is this one right or left? Well, this is anatomical view because the opposite, the posterior view, has this cavity in the back. Okay, so if this is anatomical or forward facing view, this head must go into the body of the person. And so if I'm looking at the person and this is facing me, this is going to be the right arm. Okay. Down at the distal end of the anatomical view, we have a ball. That's right here. And we have another piece that looks like a chest pawn. The ball is the capitulum, and the other part is the trochlea. The capitulum is rounded or surrounded by the radius as it flexes. The trochlea is surrounded by the ulna as it flexes. The ulna coming around the trochlea goes into this coronoid fossa. The head of the radius comes around the capitulum and goes into the radial fossa, not named here. I'll show it to you. Okay. Anterior view again. Here's the ball, and this ball is the capitulum. This portion here with the groove in it is the trochlea. Above the capitulum is the coronoid. I'm sorry, is the radial fossa. And above the trochlea here, where the star is the coronoid fossa. If you haven't learned these yet, they are a bit challenging. And the coronoid fossa, again, is on the side towards the heart. I don't know if they named it that, but that's the way I've always had to remember it. I'm going to go back up to this one. Here's the head. Here is the anatomical neck. And the surgical neck is down here, where it will often break. Lateral to the head, you have the greater tubercle. And next to that, coming back, is the lesser tubercle. In between the two, the intertrabecular groove. Here's the greater tubercle here, and the lesser tubercle, this starred point. The intertrabecular sulcus in between the two. At the distal end of the humerus, you can feel them on yourself. You can grab both sides of your lower upper arm, and you'll find these two projections, the medial epicondyle, and on the other side, the lateral epicondyle. It's not shown here. Uh-huh. Here's the lateral epicondyle, and here's the medial, the sharper The ulna looks like a wrench, okay, the mouth of which is the trochlear notch, but the top or head portion of which, this large structure, is the olecranon process. Put your finger in the mouth of the trochlear notch, bring it forward to this lip, and that's the coronoid process. The coronoid process over here is right here. And down at the distal end is a point called the styloid process. Styloid process of the ulna. Here's the radius. We'll start with the styloid process this time. It's down here. And on the other side is the ulnar notch. These notches are always where two bones come together. So you have the ulna and the radius. Here's the head, neck of the radius, and the radial tuberosity. Tuberosity, don't forget that. Okay, here's the hand. Okay, I'm not going to go through the phalanges. I hope that's okay. But the Roman numeral items here, these are metacarpals 1, 2, 3, 4, and 5. Metacarpal 1 comes down to the trapezium, which is a carpal. Metacarpal 2 comes down to the trapezoid carpal. Metacarpal 3 comes down to the capitate. And 4 and 5 share the hamate. Underneath the trapezium and the trapezoid is the scaphoid, sometimes called navicular again. I don't know why they chose one name in the foot and one in the other. Both are acceptable. This is the scaphoid, and this is the lunate. This is the triangular. You can barely see why they call it triangular. And you have one more on the other side, the pisiform. This one at the bottom has labeling, okay? And I've gone over it, it's fine. The P, however, you should know, stands for pisiform. The H for hamate, C for capitate. T3 is actually T2 is trapezium, and then we have trapezoid, T3. S for scaphoid, L for lunate, T1 for triangular, and then P for pisiform again. Okay, we're finally coming home here. This was the lecture on Tuesday. We also did this today with the real bones. Get these spines down. Anterior superior iliac spine versus posterior superior iliac spine. Try to get those down. And if you can't get something from the notes that you have here, Google another picture for yourself. There's tons and tons of this stuff. Okay. Underneath the spines, we have the greater sciatic notch, ischial spine, lesser sciatic notch. And then we have the rest of the ischium coming around to the pubis, the obturator foramen here, the acetabulum here. On the male versus female pelvis, this will be asked. Remember that the female pelvis is at least 90 degrees, despite what they say here, at least 90 degrees. And the male pelvis is never really 90 degrees. It's quite a bit smaller. You'll be able to see them side by side. Okay, we saw this today, and I don't know what more I could say on it. This part of the fibula up here is the head. The other end is the lateral malleolus. So even if they're stuck together, in other words, articulated with the tibia, you're going to have to know head versus lateral malleolus. If you have any questions about the foot, because I just went over it, I don't mind answering them again. That's not a problem. But you're going to have to shout out that you got a question. One thing I like about this presentation of the knee, they call this the lateral collateral ligament and the medial collateral ligament. Collateral meaning that there's going to be two sides, and the two sides are lateral and medial. Some books don't use that method, but ours does here, and I think it's to be preferred. Okay. Any final questions? Because I just feel that that was too recent today, that last little bit.
Yeah, I have a quick question.
Sure.
For the sacral foramina, are they counted separately or together? So like the anterior and the posterior, are there 8 total or more?
Okay. On the anterior sacral foramina, there are 4 pairs or 8. On the back, there are 4 pairs or 8. Okay, so does that answer your question or not?
Yeah, it does.
Okay.
I also had one more question. If you were to look at your foot, the highest portion, the highest bone that's on the top, would that be I am totally spacing on the name.
It's okay.
Would that be like your second cuneiform that you can feel right on the top of your
Now, I'm not sure that you're talking about the same thing I'm thinking of. When you say the top of the foot, it's the talus.
Okay,
So,
I'm meaning more, not so much where your ankle is, but like mid-foot, right behind the metatarsals. At
right,
least on my foot, I can feel
right,
like a
right.
bump or
Okay,
a protuberance, and
right, right behind the uh, metatarsals will be the three cuneiforms in the cuboid.
right. Um, I'm just a very physical learner, so, like, me, it helps to, like, feel the parts of my body and actually be able to tell what bone it was, and there's a very bony portion, at least on my foot, and I'm not sure if it's more like the navicular bone or a cuneiform, and if it is a cuneiform, which it would be, basically.
Yeah. Well, depend if you decide it's a cuneiform. Deciding which one it is pretty simple because cuneiform one is behind the big toe, and then two, and then three. You know, do you have this bump on both feet?
Yes.
Okay, it's probably real, but
It's okay. I have a friend who's in, grad school, and she was trying to figure it out with me, and she just wasn't sure either. So, I figured I would ask.
okay, you could always put your foot in front of the screen.
Think I'm
That,
gonna pass.
yeah.
Probably everyone doesn't wanna look at my foot, but, it is all good. It's not like a necessary need to know, I was just curious.
If you don't want to put it in front of the screen, well, you can send me a picture. I mean it. Figure it out.
Okay,
Okay. I'll be waiting for that picture.
those are all the questions that I have, though, if
Thank you.
anyone else has questions.
Okay. Well, you're welcome, of course, to email me over the weekend with other questions that you have. Sometimes it's best to send a picture along of something that you're concerned with. Uh, I think you're going to find that you just got to get down and do it if you haven't already. That is, do the memorization because that's all this is. It's uh, not going to be the toughest part of the course. And that I shouldn't maybe say because then somebody say, "Oh no, it gets tougher." Uh, yeah, it does. Yeah, but I've noticed that people who score very well on the first exam generally score very well all the way through the rest of the course. So, okay, well, I'm going to turn it off then. Okay, and we'll see you on or hear from you on Tuesday. We may not see each other. You don't need to see me, but if you have questions during the test, you can ask. Uh, I don't think you will. Okay, 2 o'clock on Tuesday.
Thank you, Charlie.
Bye bye.
Bye.